My name's Professor Andy Gennery. I am Professor of Pediatric Immunology and Stem Cell Transplantation. I work at the Newcastle University and also at the Great North Children's Hospital in Newcastle upon Tyne in the UK. I have been in practice for many years now, over 20 years, and I've been asked to talk about the future perspectives for treatment utilization of extracorporeal photopheresis in the treatment of graft-versus-host disease. I'm a pediatrician, so I'm going to give you a pediatric perspective on this. Some of what I say, I'm sure, will be relevant for adults, but I don't have an adult practice, and therefore you just need to bear that in mind when I say something. So extracorporeal photopheresis, or ECP, is an apheresis procedure that's used to treat both acute and chronic graft-versus-host disease. I think it's probably got a unique mode of action in that it's an immunomodulatory treatment rather than an immunosuppressive treatment. It's been available for many years now, over 40 years, but is perhaps becoming more mainstream. It's safe to deliver. There are relatively few side effects of the treatment. The main side effects are related to line use. So if there's an indwelling venous catheter or indeed a peripheral catheter, then the main side effects are related to using that, either infection, potentially bleeding from that. In young and small low body weight patients, there may be issues with hypotension when blood is drawn from the patient into the apheresis machine for treatment, can lead to hypertension, and that can be avoided by blood prime of the machine prior to using it and connecting it to the patient. And then there's a potential problem with photosensitivity if patients are sensitive either to the methoxysorolin, which is the activating agent used in conjunction with ultraviolet A light, which patients may become sensitive to. And then also patients need to protect themselves from sunlight immediately following treatment so that there are not adverse effects. I have to say, that's not a problem we see very often in the northeast of England. Certainly in the UK, there's now better access to ECP in a way that wasn't true, gosh, even maybe 5 years ago or so. And I would say it's now become recommended as a second or third line treatment for acute or chronic graft-versus-host disease in many institutions. The process, so it's a unique mode of action in that it is immunomodulatory rather than immunosuppressive. And that's not true for most of the treatments that we use for graft-versus-host disease. It leads to a downregulation of dendritic cells, which in turn leads to downregulation of activated T lymphocytes, which are causing the graft-versus-host disease. And it also leads to an increase in number and probably function of regulatory T cells. Importantly, patients being treated with ECP maintain an antiviral activity, and also for those who are being treated for malignancy, there's often an anti-leukemic activity which is also preserved. And again, that's different from our conventional immunosuppression. We know that it's effective both in a pediatric and adult population, and it's effective for a number of different types of graft-versus-host disease, so certainly cutaneous, but it's also effective in hepatic and gastrointestinal acute GvHD, and it's effective in chronic GvHD as well. And that's true in both the pediatric and an adult population. As I say, there's fairly good access, certainly in the UK, to it. And the main drawback is probably that patients need to be attached to the machine. And that's going to be for 2 or 3 hours whilst they have treatment. And the frequency of treatment depends on the type of GvHD that's being treated and also where they are in terms of the treatment cycle. So certainly for acute GvHD, then treatment is going to be weekly for 2 or 3 days. and then spread out after a couple of months, probably to maybe every 2 weeks or every 3 weeks. For patients being treated for chronic GvHD, then the treatment may only be every 2 or 3 months, in fact. So maybe not such a long time in that situation, but certainly in an acute and early GvHD stage, patients will have a fairly intensive treatment course, which will involve trips to the hospital if they are not already inpatients, and as I say, will involve a couple of hours attached to the machine. However, in terms of where it goes in the future, I think it's difficult to say, and I'm not sure I can really answer that question. Until about 5 years ago, it really was probably one of the most effective treatments that we had following failure of treatment with steroids or resistance to treatment with steroids. And certainly for patients who were getting significant steroid side effects, it was a good option. More recently, over the last couple of years, a couple of agents have become available on the market and indeed are now licensed, certainly for some patient populations, which I think are changing the landscape of treating GvHD. And these are the JAK inhibitors, such as ruxolitinib, and also the ROCK2 inhibitors, such as belumosudil. These are also effective treatments, certainly in chronic GvHD, and for ruxolitinib, there is some evidence that it's effective for treating acute GvHD as well. I don't think that evidence is yet available for belumosudil. And so the question today really is, where do these agents fit into a treatment algorithm, and where does ECP find a place amongst that? And I really don't know. The problems with ruxolitinib and belumosudil is that they are in some ways classic immunosuppressive drugs. So whilst they're new agents, their mode of action is still by suppressing the immune system, and therefore there are side effects associated with that, particularly patients becoming susceptible to infection. I don't know what the data are on, for instance, preserving the anti-leukemic effect when using these agents, but they do have side effects which we don't see with ECP. On the other hand, ECP takes a while to work. When you give a treatment on one day, it's going to be several days, if not a few weeks, before you really start to see good evidence that the GvHD is coming under control. Whereas ruxolitinib, belumosudil are firstly much easier to administer because they can be given IV or orally. And also they start to work much more quickly. So I think going forward, we really do need to see some good clinical trials looking at a combination treatment with either JAK inhibitors or ROCK2 inhibitors in combination with ECP, so that we can work out for patients what is the best treatment, and is the best treatment one of the newer agents or ECP, or is it a combination of one of the newer agents with ECP, and how do we give that combination? Which one do we start first? Once we've start to see a response to the GvHD, which of the agents do we start to reduce first? One of the JAK inhibitors or ROCK2 inhibitors, or indeed do we start to reduce ECP frequency first? And I think these are open questions. I think for patients, it's actually quite an exciting time, because it does mean that for patients who are experiencing graft-versus-host disease, there are now a number of effective agents available which can lead to cure, but quite how we administer them and in what order, I think that now needs to be determined. Thank you very much for listening. I would be happy to take any questions by email if you have any, and I look forward to seeing how the field develops over the next few years.